Hi, everyone. Welcome to today's session. We're going to give everyone a couple more minutes. I see people still trickling into the room, so we're just going to pause for a couple minutes and let people get into the room. And I'll share my screen so we can be ready. Okay, we are 2 minutes past 3 o'clock, so we'll just get started. Hi, everybody. Welcome to today's session. Happy New Year. This is the first Be Informed session in the new year. So Happy New Year, everybody. My name is Shreya Koirala. I'm the program coordinator for Hepatitis B Foundation, and it's my pleasure to welcome you all for today's Be Informed session. Before we move on with the session, a couple of housekeeping items. All the attendees on today's session are going to be on mute. We do have a chat function though, so please feel free to introduce yourself in the chat. Let us know where you're from. There is also a Q&A box. So during the session, if you have any questions for us, please drop it into the Q&A box or the chat button. And once the presentations are over, we'll get to your questions. I would also like to let you know that this session is being recorded. We will share with you the slide presentations once in the next few weeks, and it will be uploaded in the Happy United website as well. Before we move forward, for everybody who's new, a little insight to the Happy United Coalition. Happy United Coalition is our national coalition, which is dedicated to reducing the health disparities associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities across the United States. As of today, we are partners with more than 50 local coalitions and national organizations in 37 cities and 27 states and DC. We do provide for our partners capacity building programs like the Be Informed session today. In addition to that, some of our more popular capacity building programs are the mini grant programs, the peer partnership program. For more information about that, please go to happyunited.org. I'll drop that into the chat also. But please feel free to go to that website. And if you have any questions at all, please feel free to reach out to me and I can talk to you more about it. For those of you who are new here, the Be Informed session is Happy United's Capacity Building Program, which is a virtual education series geared toward anyone interested in learning more about hepatitis B. That includes patients, family members, community advocates, healthcare providers, public health professionals, and community members. We have sessions every other month on the third Tuesday at 3 p.m. Eastern Time, and our sessions are typically 45 minutes long, but sometimes goes up to the full hour. Once the session is over, you'll see on your screen a survey pop up where we'll be asking about the technology of the whole session and if the content presented in the presentation was useful to you, or if you have any additional feedback or recommendations for us moving forward. Our next Be Informed session will be on March 17th. The topic that's going to be discussed and the registration details, I'll provide that details to you very shortly. And I think it'll be included in the email that I sent to you with the recordings and the slides, actually. Having said that, we can get started with today's presentation. I'm going to give a minute for my colleague Fiona, to share the screen and we'll get started. Give me 1 second. I'm pulling up my notes. Today we are going to be talking about a newly published study called Boosting Diverse Communities' Participation in Clinical Trials, What People Living with Hepatitis B Must Know. This study draws on mixed methods data from 10 communities across the US, and it really looks at how things like access to accurate information and community-centered partnerships can make a big difference in who participates in hepatitis B clinical trials. This presentation is being done by my colleagues Yasmin Ibrahim, Fiona Borundi Jenkins, and myself, Shreya Koirala, and we'll be walking you through what the study found and why it actually matters in real-world settings. Next slide, please. Before we move on, we just want to acknowledge and thank our co-authors and collaborators who helped co-write this paper and make this study possible. I'll quickly read out their names. Me Dong from Asian Center of Southeast Michigan, Ibrahim Ashrankare from African Services Committee, Muhammad Ali from Somali Health Board, Yung Hua from Vital Access Care Foundation, Ellen Tham from Center of Asian Health, Rensley and Kenson Alec from Micronesian Education for Liver Wellness Program, Ashley Shea, and Tanya Machado. Next slide, please. Just to give a bit of background on why this study matters, according to the World Health Organization 2024 Global Hepatitis Report, there are about 254 million people worldwide living with hepatitis B, which we'll refer to as PLWHB. What's concerning is that hepatitis B-related deaths are actually increasing. They went from around 820,000 in 2019 to about 1.1 million in 2022. Here in the US, up to 2.4 million people are living with hepatitis B, and these are predominantly foreign-born individuals from regions where HBV is endemic, so the burden isn't evenly distributed. Despite this, participants in hepatitis B clinical trials don't reflect the global populations most affected by the disease. In fact, many of the regions with the highest HPV burden, which are Africa, South Asia, East Asia, and the Western Pacific, are significantly underrepresented in clinical trials. Next slide, please. So when we look at the problem the study is trying to address, a big issue is that the US clinical trial data consistently shows underrepresentation of racial and ethnic minority populations. Across many programs, white participants still make up more than 50% of trial enrollment. At the same time, Asian, Black, and Hispanic populations remain underrepresented, even though the US Food and Drug Administration has placed a strong emphasis on improving diversity in clinical trial. We do still see these trends. Participation is especially low among communities coming from regions with high hepatitis B burdens, which is concerning given who is most affected by this disease. Some of the key barriers that keep coming up include mistrust of research, lack of accessible and culturally relevant information, limited time and resources, and low awareness that clinical trials are even an option. And ultimately, when populations that are most impacted by hepatitis B are underrepresented in trials, it limits how generalizable the results are and reduces confidence in how effective treatments may be for those communities. Next slide, please. The aim of this paper is pretty straightforward. We wanted to understand how people living with hepatitis B currently think about and perceive clinical trials. We also looked at where people actually get their information from and who they trust and which communication platforms work best for reaching different communities. And finally, we also wanted to identify the specific informational needs for people living with hepatitis B across diverse racial and ethnic minority communities, so outreach and trial design can be more inclusive and effective. Next slide. This study used a mixed methods design consisting of a qualitative and a quantitative arm. There were two main parts to the study. The first was the quantitative arm, which was a global online survey. The second was the qualitative arm that included a virtual in-depth interview and focus groups. Both the survey and the interview guides were developed and reviewed by an expert panel that included people living with hepatitis B, public health researchers, and epidemiologists. The questions were mostly focused on clinical trial participation, perceptions, barriers, and decision making. The two arms were conducted one after the other. We started with the survey first, and the insights from the surveys helped us refine the qualitative interview and focus group guides. So the two methods that we used for this study complemented each other. The survey was anonymous, cross-sectional online survey conducted through SurveyMonkey. It ran from January through October of 2023, and it was available in multiple languages. It used convenient sampling with recruitment supported by community partners and in language supported by community partners. Sorry. Participants in the qualitative arm were adults over 18 years of age and living in the United States with a self-reported diagnosis of chronic hepatitis B. Next slide.
Thanks, Shreya. So we really wanted to highlight the major role that our community partners had in this study. As you all know, community-based organizations have deep knowledge of the people that they serve, and they're truly trusted by their community. We wanted to ensure that our study was rooted in these partnerships. So we had partners help from the beginning of the study. So at the start, they helped by reviewing and ensuring that the translated data collection tools, like the survey and the focus group guide, were clear and culturally accurate. They also helped with recruitment for both arms of the study by posting about the survey and the focus group opportunities on their social media channels. And they also had community navigators conduct outreach to potential participants to discuss the study. These navigators also took on the important role of facilitating the focus groups, of which many were conducted in a language other than English. These efforts all strengthen the community's trust in the study as well as its cultural appropriateness. Now for the demographics, we had 680 survey respondents in the final analytical sample. Most were male, Black or African American, and lived in Nigeria. Nearly half have received their Hep B diagnosis in the last 5 years, and 95% of survey respondents have never participated in a clinical trial. For our focus groups and interview participants, we had 36 participants in total, with 30 across 6 different focus groups, and 6 people participated in individual interviews. Most were female, and most have been diagnosed for more than 10 years, and 89% have never participated in a clinical trial. And we just wanted to highlight that the West African focus group had participants from Senegal, Burkina Faso, and Cameroon. We won't be going over everything that we highlighted in the manuscript, so for a quick overview of the results, we found that in both arms of the study, there was limited existing knowledge of Hep B clinical trials in the community, and there are many existing misconceptions about trials. We'll be going over our findings on people's existing knowledge, sources of information, and the community's suggestions to improve trials recruitment and enrollment efforts. We found that while there is limited existing knowledge about clinical trials within the Hep B community, with only 27% of survey respondents and some participants in the Chinese, Somali, white, and Black communities, there's still high willingness to participate if offered the opportunity. 85% of our survey respondents indicated that they were willing to participate, and only 1.4% responded that they were not willing to participate. These findings highlight that with proper outreach, there's great potential for strong engagement and successful recruitment with these communities. In both arms, we found that people are very receptive to learning about hepatitis B clinical trials and opportunities for participation. Diverse communities really need to have access to information about trial processes, safety, ethical guidelines, the risks and benefits, as well as the importance of trial participation. And this part is the most important, they have to be able to easily talk to researchers or a research spokesperson, like community navigators that have access to trial information, so that the community can find out more information and feel more confident in a trial. Of those who indicated that they had some existing knowledge of trials, again, this was only 27% of survey respondents and a few of the community participants. They learned about trials through digital sources like online and news-related media and in-person sources, including healthcare providers and trusted community organizations. However, we found two major missed opportunities when asking this question in both arms. As you can see, within the people who had existing knowledge, only 27% of the survey respondents got this information from their doctors, and only 13% of this group received information from their trusted leaders and community organizations. So that's one big takeaway. We also posed the question to all participants that if they're asking if their doctor has ever discussed participating in trials with them. And we saw that most survey respondents, 83%, said no. And many participants in the focus groups had also not discussed clinical trial information with their doctors. And we believe these findings indicate a major missed opportunity for trial developers to engage the community through these trusted sources, which can potentially expand their outreach, build community trust, and ultimately enhance their recruitment efforts.
Thank you, Shreya and Fiona. And so we wanted to learn from participants about how they would like to learn about clinical trials and be informed about clinical trials. And we learned from them how clinical trial sites can tailor recruitment strategies to successfully recruit participants, especially from immigrant and other underrepresented communities. And so participants told us that local and community-based radio, newspapers, and social media would be successful platforms to reach them. And they also specified messaging platforms that are more commonly used among their community, more than other more known or popular platforms. So they mentioned WeChat, Zalo, or Kakao Talk. I think that's the right way to say it. Trusted Messenger was also a very important channel of communication. So, as Fiona explained earlier, when we asked them about how they learned about clinical trials, the small percentage or proportion who knew about clinical trials, they didn't really know it from their trusted messenger. But when we asked them in conversations about how they'd like to learn about clinical trials, they mentioned trusted messenger. So this included their community leaders and their healthcare providers with whom they already have long-standing relationships. Not surprisingly, they also highlighted the importance of in-language communication. However, it's important to emphasize here that translation or translating the material does not work alone, as we will see in the coming slides. Translated information must be delivered through the proper channels and reinforced through the trusted messenger. Participants also shared a list of information they were interested in learning. This table has a long list of information they'd like to learn about. I'll give a couple of examples, but the paper is open access, so feel free to check it out and read more. For example, safety was a major theme, as some emphasized that the stage of trial, like phase 1 or phase 2, is very important, that this would indicate whether the tried medicine has passed the initial safety testing. Others were more specific and wanting to know more about safety profile of the medication, of the medicine being tried, and side effects and potential harms. Others were interested in learning more about the credentials of the trial medical team, the doctor leading the trial, and with whom they will be interacting, and how easy the instructions to receive the medication that they will be using during the trial. This is among many other, as I said, the list is long. There are information pertaining to logistics and time commitment. So all of these are important information to provide to potential participants to be able to make an informed decision about whether to participate in a clinical trial. Next, please. I want to pause here and talk about the role of community-based organizations in clinical trials, because this slide is really about you all and the impact you already have. Community-based organizations are often the most trusted source of information in a community. You are the gatekeepers, the connectors, and the people community members already turn to when they are trying to make sense of complex health information or health situations or navigate the health system. That puts you in a unique position to bring clinical trial opportunities to people who might otherwise never hear about clinical trials. What we heard from our survey respondents and through community conversations is, as we've been emphasizing in the past couple of slides, there's a missed opportunity. As Fiona mentioned, only a small number said that they learned about clinical trials through their community organizations or healthcare providers and community leaders. And that doesn't reflect a lack of interest or commitment. It really points to a gap in communication and connection between trial teams and community organizations. This is where clinical trial teams have work to do, building continuous. Next, please. Yes. Thank you. So this is where clinical trial teams have to build continuous, not one-off communication with community-based organizations. And this also means keeping you informed about upcoming research opportunities and making sure you have access to clear, accurate, and usable information that you can share confidently with your communities. And when those relationships are strong and ongoing, engagement with underrepresented communities improves. Working with community-based organizations early before a study launch helps ensure that study procedures are patient-centric and community-centric and responsive to real community needs, and that outreach is culturally appropriate and meaningful. And when that happens, community-based organizations can do what they already do best, inform their communities, their community members about opportunities, build trust, and support enrollment and retention in ways research teams or clinical trial teams cannot actually do on their own. It's about recognizing the critical role community-based organizations play in this and building true partnerships with the community. And that's something I think clinical trial teams with community organizations need to work on. Next, please. So while collaborating with our community partners, we learned a lot, recruitment and stigma. Some community leaders and some community organizations had really a hard time recruiting participants because of fear of stigma, and this was clear in more organizations or more communities than others. Some community organizations were actually not able to recruit any participants, and despite being in agreement on the study and everything, a few months in, they had to stop. We offered some flexibility. We offered one-on-one interview options so that folks who don't want to be in a group can have confidential interviews, but that helped with some communities, but in others that didn't really help. Recruitment strategies also was another lesson learned. Recruitment in our study. So we found that one-on-one recruitment worked better. It meant that the community organization staff may take longer time to recruit and have more effort. or exert more effort to really recruit participants in our study, but that definitely yielded better results than other strategies. Another community organization did post on social media, and that ended up in email being in the inbox being flooded with ineligible participants and scammers looking for the reimbursement. So we had to stop that and switch gears. There was also a need for more training for some of the community staff who facilitated the focus groups so that we ensure that there is consistency in the responses and data we're getting. Some may be asking leading questions to the participants, leading them to a certain answer over the other. So training on facilitating focus groups was definitely a key. We did that, but in our experience after the fact, we found that maybe we needed to spend more time training some of the community staff. And then we also had to be very flexible with the honoraria for participation because not everyone can handle gift cards or online payments. Some preferred checks, some preferred even cash in hand. And so we had really very high flexibility on how community organizations can pay or remunerate participants in this study. And that helped a lot. As we mentioned earlier, that translation helps, but it's not a silver bullet solution. So we did translate our survey into, I think, 9 languages. However, we were surprised that we didn't really get many in-language responses, and that was a lesson learned because I don't think we promoted the in-language survey over or through the right platforms. We promoted it through our social media platform, which means most of our visitors already understand English. So we ended up with very few in-language responses. So if this happens again, we should definitely look into many of the strategies that our participants taught us and shared with us on how to reach out to them with in-language survey. Next, please. So I don't know if anyone from the participants is one of our collaborators. I've been looking into the attendees' names, and I'm not sure I recognize many, but if any of the attendees was one of our collaborators on this study, please feel free to share your reflections on the study and what might be lessons learned. I'll pose the other question for all attendees, which is from your perspective and or experience, if you participated in research before, how can community-based organizations get more involved in research, even public health research like the one we're doing now? I'll pause here for a few seconds to see if anyone is interested to share their thoughts.
Please feel free to raise your hand if you have a comment. If you feel comfortable typing it in the chat, that's fine too. Please feel free to do that.
I don't see hands raised. All right, I'll keep going, and I think we have also an opportunity for questions and answers and reflections after that. So next, please. We just wanted to give a shout out to our Happy United partners who collaborated on this study. It wasn't an easy one, but they were willing to go the extra mile to help and support and reach out to their community members and recruit and conduct the study. They were very communicative with how things are going and like where they are and asking questions. So I really want to give them a shout out for that. Next, please. And as we mentioned, it's an open access paper. I know Shreya shared the link in the chat box, and this QR code should work as well. Feel free to read it on your own, and if you do, and if you have questions, please feel free to reach out to Shreya, Fiona, or myself, and we'd be happy to chat more about it. Next, please. And happy to take any questions.
Please drop any questions you might have in the chat or the Q&A box. While we are waiting for questions to be posted, I prepared a few so we can get the discussion started. So, my first question is, were there any populations that you feel this study still does not maybe adequately capture or reach?
Yeah, I mean, as I mentioned in some of the lessons learned, there because of fear of stigma and discrimination, especially within the community, because with every community, like it's kind of like a small. We always say it's a small world, and within the community, it's even a smaller world. And so people didn't want to disclose their status, and were fearing to be their status to be disclosed. So the southeastern community was really very difficult to recruit, and we ended up not having participants from that community here in the US. So I was really hoping we would be able to connect with them and hear their thoughts. Even with the one-on-one interview option, the community organization wasn't able to recruit.
Fiona, did you have anything to add to that?
Not nothing crazy. I think there's always opportunity for us to expand the people that we engage with, especially within the different research projects that we do. So we have amazing community partners that have connected us with so many different community members. And I think, if we were to do this study again, we'd try to do even more focus groups with a different uh, group of West African immigrants in the U.S. and a different group of the Chinese community in the U.S. I think there's always room for more more diversity and more work with different groups.
Awesome. And for our attendees too, you all work on the ground with so many different communities. If you have recruitment strategies for your programs or for the research you're doing that has really, really worked for you, let us know. Email us, reach out to us. That would be helpful. We're always trying to learn new things. We're always trying to reach more members of our communities. So that would be really helpful to know. Moving on, my other question is, in your experience, what matters more for participation, logistical support or relationship building? And how does this study inform that balance? Yasmin, do you want to go first?
I was going to ask Fiona if she wants to go first.
Sure. So I think relationship building is extremely important. I think the Hepatitis B Foundation has years and years of established relationships with different community partners, and that is a big reason why we're able to have such a great and diverse and multifaceted group of participants, especially for the focus group and interviews. It's because we have those established relationships and people recognize the Hepatitis B Foundation. And as we do more research and do different projects and work with the community more and more, like the community starts to know us, not just as HBF, but also like who we are. Like I'm Fiona, Yasmin is Yasmin, Shreya, you're Shreya. I think that's really important that they start to know the people within the foundation and know that, we want to hear them and we want to help them. Um, Logistics are also very important. It's especially with a global study, um, getting a survey out to people around the world is difficult. And we have great community partners around the globe that have helped with that. So both are important in different ways, I think.
Yeah, thanks, Fiona. I can answer that also from a lens of clinical trials. I think relationship building, I agree with Fiona, is would be more important. Logistics are also very important, especially with how so people who are immigrants or belong to minority populations already face a lot of challenges navigating the healthcare system, navigating day-to-day life, sometimes working two jobs, and there are a lot of um, more social and financial dimension to their day-to-day life, and so logistics would be very important. But if I have to answer that question, I would still think that building relationship and building trust would be of paramount importance, because um, once a healthy and trustful relationship is built with the participant, they will be able to communicate all their needs and logistical challenges, and the clinical trial team, would then be able to support them and facilitate it. The other way around as well is when the clinical trial team has this empathetic and 360 view the uh, of the individual's life rather than just a participant, they would already upfront make support available. And so I think it goes back to seeing a person as a person and a human being, and building a trustful and healthy relationship with participants, so that it from there, I think everything can run smoothly and in a way better direction. And I see a very important comment that Rob made in the chat box, and I agree with you. I mean, things are now even more difficult. I don't know about research or clinical trial, because people are not going to their healthcare visits and essential needs, and that is already affecting all aspects of life. So I agree, sadly.
Yeah, I also wanted to touch on that too. I think this is a whole nother aspect of why it's important that clinical trials learn from the community and what they need, and making sure that they offer solutions to potential participants. If a participant is not comfortable leaving their house to go to a trial activity, appointment, anything, the trial should be and must be able to offer a different way for them to participate, whether it be at home types of appointments, care going to them, or mobile clinics within their neighborhood. I think there's many different ways that trials can navigate this horrible uh, time right now if for potential participants that would be nervous about attending or participating. So thank you, Rob, for bringing that up.
Yep, I agree. And I think this is also where relationship with the community becomes important, because people who are participating in the trial, community members, if they have a good relationship with the organizations, are able to talk to them openly about the barriers that they are facing, then we are going to be able to take some action or come up with a plan that helps us get through that, and kind of helps with the logistical side of things too. Um, so I don't see any other comment or a question popping up. If you do have any questions that you think of after the session is over, I've dropped all of our emails in the chat. So please feel free to email us. We're responsive. We'll reply to you. We'll get you more information. Thank you so much, everybody. I hope this was helpful and this was an educational session for you all, and this is helpful. Thank you again for attending the session. We will see you again soon at one of our webinars or a Be Informed session. And have a great day. Bye, everyone.
Thank you.
Thank
Thank
you.
you.
Bye.